Thank you, and thank you to the organizers for organizing such a great collection of talks. I hope you have energy for one talk more before we go into the next stage of the sessions. My instructions were to talk about management and treatment, and when I was working on the talk, I decided to restrict myself to the 4 prototype diseases: CAPS, TRAPS, and HITS, and FMF. So I hope I'm not disappointing too much. I think a lot of what we learned from these diseases can be sometimes extrapolated to other diseases. Many of the other diseases are still so rare that there's 5 or 10 patients known, and all that we know about the treatment is basically case reports. So I couldn't really put trials together. So that's why I restricted myself. Oh, and I forgot to put in a disclosure side. At some point or other, I've been a consultant in many of the IL-1 producing companies, except for Rilonacept, but the others, so that it's a bit even distributed. So in the content, I will start with a case, just to set the scene. And in the first part of my talk, I'll focus on drug treatment, and that will be largely focused on IL-1 inhibitors. I'll only briefly mention the other drugs. Then, as a transition, I'll introduce a second case, and then in the last part of the talk, I want to focus on the non-drug management of patients' problems in daily clinical practice, and also mention something about pregnancy and how to deal with that in these patients. So the first case, this is a young woman. You see her picture there. She's actually happy to have her picture because she thinks it's important to let more doctors know what her disease is like. So she had symptoms from birth with rashes, fevers, a chronic meningitis, bone problems, a growth retardation, and the diagnosis was not clear for a long time. So she was treated with high-dose prednisone and NSAIDs. She had some possibly comorbidity with urethral reflux and recurring pyelonephritis. In 2004, a diagnosis of CAPS was made. She's mutation negative, I have to say, although we didn't check her for somatic mosaicism. And she was started at the time by the pediatricians on Anakinra. I'll go into details later. When Canakinumab became available for CAPS patients in the Netherlands in 2012, she was switched to that, and she did very well on those IL-1 blockers, so she didn't need any of the prednisone or NSAIDs anymore and was practically disease-free, although she still had the damage that she had resulted from her early disease, which was already done, the damage. And she got some more problems. She developed end-stage renal failure. The cause is not exactly clear. It doesn't seem to be amyloidosis, but more likely related to her reflux and pyelonephritis and the NSAID use. But anyhow, she received a kidney transplantation. We switched her back to Anakinra for that, which she didn't like, by the way. The transplantation went well, without major complications, and at the moment she's doing well. Since her transplantation, she's only had 3 relatively minor infections, despite her immunosuppressive drugs. She is wheelchair bound due to the damage to her bones, but she is living on her own with some assistant living facility, and she has a job at a children's daycare center, which she enjoys very much, though it may contribute to her norovirus infection probably. So that's a case of a CAPS patient that responded well to IL-1 treatment, just as an example. And we've heard a lot about interleukin-1 beta already, so it's not a surprise that in CAPS, where there's an NLRP3 mutation, of course, blocking IL-1 will be beneficial. Before that was available, Anakinra was first tried about 2002, 2003. Before that it was available, it was much harder to treat. I'll show you a lot of these graphs from a group effort here that was written up by Nienke ter Haar. In this paper, we collected the literature. It's kind of older literature up to February 2012. And there's also Eurofever data. Eurofever is a registry database. It's different from the Australian database. It's more a database of known patients. So it focuses on collecting clinical data on the patients that already have a diagnosis. It's mainly children because it's a pediatric effort, although adults are also included. And of course, there are mostly European patients in there, although it is open, I think, internationally. So this is just the data that she had for that she collected for the treatment for CAPS patients for before the biologicals. Green, complete response, yellow, any partial response, and red, failure. With all the limitations of case reports and this database, you can see NSAIDs were tried, had some effect, but not really that much, and corticosteroids were, of course, given, but no one was really happy with the results of that. So that changed when Anakinra came about. So what is Anakinra? In regular human biology, you have IL-1 beta, which combine the IL-1 receptor, and you also have this endogenous IL-1 receptor antagonist, which inhibits the receptor. So it's the balance between IL-1RA and IL-1 which determines how much inflammation there is. So in a situation where you have a lot of IL-1, a relatively little IL-1RA, you get more IL-1 beta signaling. And that's what the pharmaceutical company made use of. They made a synthetic version of our own IL-1RA. So they just basically add in more of the IL-1RA, which blocks more of the IL-1 receptor, blocking IL-1 signaling. And that was quickly used in a lot of patients, or in small numbers of patients in a lot of case reports. And the results were so, in the autoinflammatory syndromes, were so spectacular that they actually skipped the phase of doing trials because it was so clear-cut and it's such an orphan disease. Looking back now, it's a bit of a shame, but it was such a wonderful drug that you could be a kind of miracle doctor to a lot of these patients. These are just two examples from early case reports where you see the acute phase protein has been high for years. You start Anakinra and then immediately it normalizes. And that was true for a lot of patients. So there's actually not any major trials. There are some side effects to Anakinra. This was a prospective study for long-term safety profile of Anakinra in CAPS patients. They included 43 patients and followed them for 5 years. They found it was mostly well tolerated, and the most adverse events happened in the first weeks and months. So it didn't get worse over time. It was really in the first period. Injection site reactions are well known. This is a very severe case. This is more regular. I see it in up to, well, I don't know, I think a third or half of the patients will get this. Usually what I see is they get it in the second week. So they start injecting daily. First they think, this is okay, it burns a bit, but I don't see the spot. In the second week, this will happen. It's a bit itching and burning, slightly painful. In most patients, if you continue the drug, despite these reactions, they will go away. So the body apparently gets used to it. So by week 4 or week 5, it will clear away and patients won't have these reactions anymore. So it's important, I find, to explain that to patients before you start the drug, that they can expect that. A lot of patients get that, but if you keep it up, it will go away again. And many of the patients notice such a great effect on their disease that they take it as, you know, as some annoying side effect, but not a reason to stop. Although, of course, in this severe case, we had to stop. Otherwise, some infections, mostly upper respiratory tract infections, and most are mild, although there have been some pneumonias described. And in this study, they found that there was no detrimental effect of just continuing the Anakinra and adding on antibiotics if necessary. So they didn't always stop the antibiotics. Not in this study, but of our own experience, there has been, I think, two or a few cases now of reactivation of tuberculosis, so pulmonary or lymphadenitis from tuberculosis. But the risk is much lower than in TNF inhibitors. And I've had a case where I did stop the Anakinra while the tuberculosis treated, but afterwards, in consultation with the patient, we decided to reintroduce the Anakinra, and he's doing well on it now. So Anakinra has a short half-life and has to be injected once a day, which has its advantages, but also, of course, major disadvantages of daily injections, which are not pleasant. So very quickly there were other forms developed, and by now this list is not complete anymore, but you have Rilonacept, which is a kind of a protein which catches away both IL-1 alpha, IL-1 beta, and IL-1RA at the same time, and prevents them from binding to the IL-1 receptor. That needs to be injected once a week, but as far as I know, it's only really marketed in the US. At least we don't have it in Europe. And then you have Canakinumab, which is a regular classical monoclonal antibody to IL-1 beta, so will only block IL-1 beta. And it was first marketed that you only needed to inject one injection once every 2 months. I'll show you that it's not fully true anymore, but that was the idea at the beginning. So this is, of course, a big advantage. And these two drugs were studied in trials, and I'll show you two of the classical ones. Oh, yeah, I put in the prices just for information. So this is in euros, but you get the idea. So Anakinra will be about 12,000 euros per year in my country. Rilonacept, as I said, we don't have it, but it would be the equivalent of about 160,000 euros per year. And Canakinumab, if you dose it once every 2 months, it will be about 66,000 euros a year. So if you need a higher dose, it will be even more expensive. And that's a big problem in these rare diseases. So the trials that were done, this is by Hal Hoffman. 46 patients with CAPS. Because if you have the small numbers and a varying disease, you have to be creative sometimes with trial designs. So you have in part 1 double blind compared to a placebo. So here you see a kind of symptom score, and here patients are randomized either to get placebo or Rilonacept, and you can really see the patients on the drug, the symptoms disappear, while the patients on the placebo injections just continue with their disease. Then there was a period of the study where all patients got Rilonacept, and after that there's a double-blind withdrawal, with the advantage that you get greater numbers that you have a placebo-controlled blinded study, and also you get a kind of idea of how long the effect lasts when you see when the symptoms are returning. And here again in this part of the study you can see quite nicely that patients that got the placebo injections, their symptoms returned after about 1 to 2 months. They started to return. So that's how long the drug was working. Canakinumab was done in a study by Helen Lackman, so it was an English study. 35 patients with CAPS. They received 1 injection of Canakinumab once every 8 weeks, so 2 months. Her design was slightly different. All the patients got 1 injection, and 34 of the 35 patients immediately got complete response. The last one did have some remaining symptoms, but later did respond. And then she also did this double-blind withdrawal. So the same way, some of the patients got Canakinumab, others got placebo, and it was blinded. And you can see the symptoms return, again in about 2 to 4 months. So, that's what we know now about those longer-acting drugs. This, again, goes back to that paper that I described before, so now I can go over it more quickly. This was what was known of what was reported in the Eurofever database by about 2011 and 2012, so that's now already 5 years ago. But you can see already by that time, many patients were on Anakinra or on Canakinumab, and the green, the complete response is impressive. So this is just in clinical practice, not controlled in any way, but just what the doctors were reporting about their patients. And this is a kind of follow-up study about the Canakinumab in cups, about what happens if you give it more in a kind of clinical setting, an open label, multi-center trial of 166 patients, no less. And so even in that study, so in the follow-up study, you see 78% of patients have complete response, and the rest do have some response, although it is not complete. And 90% of the patients keep on having a very good response on IL-1 blockers. They had the same kind of adverse events. Headache is also sometimes reported, but mostly it was these milder upper respiratory tract infections. But what they did report is that in this, so in a more clinical setting, near about 25% of patients needed a dose adjustment or frequency adjustment, so they needed a higher dose, and even 1/3 of the children. And we see that in clinical practice that you sometimes need to increase the dose, even independent of the growth of the child, and in adults as well, although I also have cases where I can, again, lower the dose. So it can be a varying effect through life. So I think it's always worthwhile, if you see the patient's doing well on the higher dose, at some point to try and lower it again, because it might be possible. To move on to the next disease, familial Mediterranean fever. We've already heard that colchicine is very successful in that, and that holds true for about up to 95% of patients doing very well on colchicine. Of course, if you look at the patients that we see in the clinic, you get the clinical impression that it might be less, but that's because we see the patients who are not doing well on colchicine more often in our clinic, and we don't see as often those patients who are doing well. Yeah, it's just a little bit about the dose, and a little bit about clinical practice. I prescribe just usually once a day, because it's much easier for compliance to keep it up, and it's as effective. And usually it has no effect on the side effects either, so once a day is fine for most patients. So colchicine was already known for a long time. It was discovered in the 1970s, actually, just because some patients with gout got colchicine for their gout and happened to also have FMF, and noticed that the FMF symptoms disappeared. So this is a very early clinical trial from the 70s, also double-blind crossover. So patients either got colchicine or placebo, blinded, and after that they were switched. So each patient had both times, and you can see here the result. Each A is an attack. So while they were on colchicine, they had far fewer attacks than while they were on placebo. Or if they started with placebo, the more attacks here than on colchicine. That it was really different times you can see, because the paper proudly states that the patients were not informed what drug was being tried or that placebo was part of the program. At that time that was considered as a plus, that it was extra blinded. Of course that's now impossible. All patients are always informed what is going on. And as always happens, there was a back-to-back publication in the same journal, New England Journal of Medicine, at the same time, of two groups, an Israeli and a Turkish group, who were both doing the same thing and having the same result. So that was already known for a long time, and colchicine is nicely cheap. It costs only about 10 cents per tablet or something like that. That is in the rest of the world. In the USA, it's very expensive. That has some commercial background. The FDA had an initiative that they wanted to get rid of all the unapproved drugs, so drugs that came in before the stringent FDA approval regimens. So they had an initiative where they wanted to encourage pharmaceutical companies to register their drugs that were not registered yet. So one company that made colchicine very cleverly did one small trial in FMF patients and one small trial in gout patients. And they just confirmed what everyone knew, that it was active. And they got approval and 7-year marketing exclusivity for one company in the USA. And they immediately increased the price from 10 cents per tablet to almost $5 per tablet. By this time, other companies can sell in the USA again, but when I checked on the website, it was still expensive to get colchicine in the USA. So that's dangerous effects of well-intentioned. I mean, the intention is of course good, but these are unintentional side effects. Of course, there are patients with FMF that don't respond sufficiently to colchicine. And as I said in the clinic, that's more than those 5%. I think it's always, or find it's always important to check what the reason is, why they're not responding. A big group is compliance. Patients have problems taking the drug nicely every day. And I can understand that. You have to take a daily drug. When you're 18, 12, or 20 years old, you get the diagnosis and you know for the rest of my life I have to take this drug, which can be a problem. Also, there's fear of side effects. There are all kinds of websites and internet forums of FMF patients where scary stories go around that colchicine is actually causing the kidney damage, is causing infertility, etc., etc. So I always have a discussion with my patients and ask them about their experiences and their fears. Of course, there are true side effects. Mostly it's gastrointestinal, so it can be, some patients can really have problems with change in their fecal continence, so they can have diarrhea or constipation and combinations of that. I find what usually helps is starting it slowly, so increasing the dose slowly. That is easier to accept, but some patients just can't tolerate a high enough dose, because that's the second reason why it might not be responding. The dose might be too low, and you just might, for a certain period of time, have to increase the dose, while maybe later you can decrease it again when the disease has gone less active enough. But then in the remaining patients, you really have patients who are not doing well on colchicine, who take it every day, who take high enough dose, but still their FMF is active. So there is a need for treatment there. And again, going back to that paper where data were collected in the literature, case reports, etc., before 2012, you can see doctors were really searching for what to give patients. All kinds of things were tried. At some point there was even intravenous colchicine. I wouldn't recommend that. It has a lot of potential risks, and I don't think it's available anymore. By now it has been crystallized out that most patients respond very well to IL-1 blockers. Alternatively, you could go for TNF inhibitors, and even IL-6 inhibitors have been described. A side note, I always continue the colchicine on patients when I add something. I always could continue the colchicine because I'm not sure Anakinra alone will prevent the amyloidosis, although theoretically you would expect it, but I haven't dared to stop it yet. So I briefly also already mentioned we sometimes try other biologicals, especially in patients where the IL-1 inhibitors are just not enough. That's usually on a trial and error basis. So if IL-1 blockers are not helping, you can try a TNF inhibitor, and there's different effects of the different ones. So some patients may respond well to an antibody to TNF, others may respond better to a drug like etanercept. And then, of course, in later years, when IL-6 inhibitors became available, I've had good response in patients that were resistant to IL-1 drugs. And that's not so surprising because those inflammatory cytokines are really closely connected, so they have an effect on each other. So if you block TNF, you also block some IL-1, etc., and IL-6. Moving on to traps. This again is before biologicals were available from that same study. You can see here it was corticosteroids and NSAIDs, and you can see that in traps actually the corticosteroids were a bit had a bit better effect. So it really can be still a drug that can have a place in traps in some patients, as well as NSAIDs in mild traps. NSAIDs might be a way to go. Colchicine, I wouldn't go for it. now that the biologicals are available, and this is, so even before 2012, patients were getting either IL-1 inhibitor or TNF inhibitor, and we discussed that a little earlier with the TRAPS cases. Actually, if you look at it, also in this not controlled, so just clinical data, you can see the Anakinra seems to be more effective than the Autoinflammatory, and that's generally true, at least for the structural TRAPS mutations. For the colchicine-resistant FMF, the TRAPS and the HITs, there's been this cluster study that we've heard mentioned, and I'll come back to that after I've talked about HITs. So TRAPS will come back then. Oh no, wait, I have this slide as well. Yes, I forgot. So there's been some knowledge about Canakinumab and TRAPS before. This is a collection nicely put together about the experiences. Some are just case reports, but there is these two phase 2 and phase 3 small trials that seem to be successful for Canakinumab, and that leads into the cluster study with Canakinumab. But let's first deal with HITs or MKD. This is again the picture what was given to the patients before we had the biologicals. And you can see NSAIDs and corticosteroids were tried. In some patients, especially in children, it's been reported that if you give corticosteroids at the start of attack, it might be useful. I haven't tried it myself, so I have no experience, but it is reported. Colchicine is not useful in these patients generally, and statins are on here as well. I decided not to go into the statin trial that we did 12 years ago. Statins, the HMG-CoA reductase inhibitors, we tried them because in a patient who got statins prescribed by his GP, who didn't realize he had hyper IgD syndrome, he thought he had less attacks, fewer attacks. And we did a small trial, and we could statistically show a reduction in number of days of illness, but the patients didn't really notice any difference on statins or off statins. So I don't prescribe statins anymore for HITs. So we generally go for IL-1 inhibitors, which do have a good effect. Although here, this is again from the same paper, but a different style of graph. Here is what is reported about Anakinra in the literature and in the Eurofever database, but for the 4 diseases, for CAPS, HITs, TRAPS, and FMF. So again, this is not controlled trials, but just clinical practice and what the doctors reported. You can see in CAPS, the complete response is much more impressive than in hyper IgD syndrome. And here as well. And that's in general the impression we have in clinical practice as well, that especially for MKD, apparently there's more going on than just IL-1 beta. Another thing, Anakinra you have to inject daily. A lot of my adult patients with hyper IgD syndrome have really well-marketed attacks and are fine in between. In the remission time, which can be up to 3 or 4 months or even longer, they don't have any symptoms. So a lot of patients came to me and asked, I don't want to inject this, give this injection every day if I, may not be ill for the next 4 months. Can't we try something that I only use it in attacks? So we decided to do that in a controlled way, and we got 9 patients to collaborate on that. So they would come to us as soon as they got their symptoms, and you can see that here, untreated, they would come as soon as they noticed their symptoms. So you can see here, this is kind of clinical score that I won't explain, it's just the addition of all kinds of symptoms that they had. And you could see they were so well familiar with their disease that when they reported, usually they didn't have a fever yet, but they were at the prodromal stage, and the fever would quickly go up and last for about 5 days. So this is an untreated attacks. And then we gave them an Anakinra injection as soon as they reported to the hospital, and that had a very nice effect. So of course they come in with the same kind of disease, at the same stage of disease, but you can see the fever doesn't really happen anymore, and the symptoms disappear within 1 or 2 days. And this was, of course, they still had to come to the hospital before they could inject. By now, most of my patients, the adult patients who are on this regimen, the on-demand treatment, they have it at home, at the refrigerator, so they can start much sooner, and they can really shorten it to either one day or just a few hours of attack. And they use it usually for about 5 days or so, although some patients have managed to shorten that so they can get by with just using it for 3 or 4 days. There's been also a small trial with Canakinumab, so the long-acting IL-1 inhibitor in MKD. This is a Spanish study in 6 children and 3 adults. They chose to begin with already a higher dose, so a double dose in every 6 weeks, because of what I told you earlier, that in HITs, IL-1 inhibition seems to be not as successful as in the other, as in CAPS, for example. And they found a nice effect. So they compared with the historical period, and they could really reduce the number of patients having an attack during 6 months in that period. So it's a good response. And that brings me to the cluster study. The cluster study is the multi-center international study that has a very complicated scheme, as you can see here. I won't go into all the details. The main part for today is this middle part, where we included a number of TRAPS patients, HITS patients, and colchicine-resistant FMF patients, and they would report at the time that they got an attack, and that's when the trial would start. And they were randomized to get either Canakinumab or a placebo. But because we found it unethical to keep them on placebo if they got severe disease, there was an escape. So if, despite the injection, they would get severe disease, they could escape an injection of Canakinumab, so they could move over to another lane. And in the Canakinumab dose of 1, so just the lower dose, but once every month, not every 2 months, they could increase to a double dose if that wasn't enough. In the second phase, there was a withdrawal that was randomized, and then there was an open label treatment period. But we'll look at the first 2 periods, and here you can see the patients at the end of the second period. The colchicine-resistant FMF HITs, or MKD, and the TRAPS patients. And so you can see the percentage of patients that reached complete response at the end of this period, these months. And we saw the tables already in the previous talks. This is just in a graph form. There is the majority of FMF patients. For HITs, it's a little less, but still interesting for a number of patients, and the same for TRAPS. Yellow is just a higher dose. So if you give a higher dose, even more HITs patients will get some response or complete response. And that's also seen in this graph. This shows you the percentage of patients that had a good response at what dose. So in blue, those are the patients that were doing well on placebo. It's a varying disease, so they were just lucky that the disease was not active at the time, I guess. Yellow is the lowest dose. This is 1 injection every 2 months. The brown and the gray is equivalent to 2 injections every month, or 1 injection every month. And the purple is even higher, is 2 injections every month. And again, you can see that the HITs patients really need a higher dose to get the same result. So that's interesting. Before I move on to the non-drug related part of the talk, this is a question I get a lot. When you have a patient where you don't know the disease that's going on, but he's severe disease, how do you know whether it's worthwhile to try Anakinra, whether IL-1 blockade might be successful? And there could be several options, of course. In my opinion, IL-1 serum concentration in an individual patient is usually not informative. If you see the slides, and we've seen slides earlier today of patients with CAPS that have higher IL-1 beta concentration, it's usually a range where the controls are somewhere lower in a range. But for an individual patient, the IL-1 serum concentration is not informative because it's more paracrine and autocrine cytokine. You could, of course, go for more basic science approach, try and catch the IL-1 secretion by PBMCs, or work with knockout mice, or all kinds of variations. That might work, might often not be available. In my opinion, just trying it is the best indicator. So if you really need something and you see a lot of inflammation going on, just a short live IL-1 inhibition and set up a kind of short trial, 1 or 2 weeks, would usually be informative enough to show you whether it works or not. This is the second case I promised. This is an FMF patient. It's a Dutch patient of Turkish origin. He had FMF attacks from the age of 1. He didn't have very severe attacks, so he would fall in what Seth Masters called the more mild patients. And at age 6, he was diagnosed with FMF and started on colchicine. And he said, and his family said, oh, he's doing fine, he has no more symptoms. But there might be something going on, as you can figure from the way I'm telling you the story. So to be continued, by age 12, 1998, he had minimal proteinuria in a portion. It was good that the physician checked this, but they didn't connect any conclusions from this. They did do the genetics. I mean, this is 1998, so the genetics was available by this time, and he turned out to be M694V homozygous in the MAV gene, so it confirmed the diagnosis of FMF. His elder brother had also FMF, had developed AA amyloidosis, and was already having problems with renal function. In his case, they nicely every year checked the urine sample and saw a slowly increasing amount of protein in the urine, but they didn't do anything else. And there were no alarm bells and no further tests done. And it's easy, of course, in hindsight to be critical of this, but you do have to remember that this is around 2000, when the idea was mainly that AA amyloidosis was irreversible and that FMF could only be treated by colchicine. You didn't have anything else. So there might be some mitigating factors. Later on, when it was 2004, he was age 18, he was transitioned to an adult internist, already sent to a nephrologist because they already saw his renal function deteriorating, and he didn't change anything in his pattern. He didn't consult an FMF specialist. And by that time, we got to know more about AA amyloidosis, of course. The first reports were already in 2001, and mainly it was in 2006 and 2007 that the reports started to come in, that if you treat patients more aggressively and make sure the inflammation goes away, even severe AA amyloidosis, in this case in the liver, can be reversed. If you get the inflammation, the acute phase response to go down, you can see reversal. But these doctors were not aware of this, so they just followed him, and he developed clearly progressive proteinuria. They even confirmed it was AA amyloidosis, but they didn't change anything, and his brother died of complications of his renal failure by this time. So in 2013, our patient also developed terminal kidney failure, and he was referred then to a university kidney center to see whether he would be eligible for transplantation. And that was the time that we got involved, because we are actually in the same staff hall as the renal experts. So they just knocked on my door and said, is there anything we should be aware of in FMF? So I saw this patient and talked with him, and it's true, he said his disease was quiet. He considered himself not to have FMF attacks anymore. So it was a bit of a misleading case, because he considered himself to be disease-free. But if you asked closely enough, he did have episodes of abdominal pain of 2 or 3 days, and he did have painful ankles, which might have been swollen once in a while, but he thought, well, everyone has that. And when I checked his CRP and SAA, it was regularly increased, so above normal, even when he didn't report symptoms. So I started him on Anakinra. Once every 2 days was enough because of his renal failure. He was on hemodialysis by the time. And he reported back to me that suddenly he was feeling much better. So the headaches and abdominal pain and the pain in his ankles and other joints was gone. So apparently he did have this inflammatory disease, but he didn't connect that with his FMF. And that was, of course, one of the problems. He was transplanted with a living-related donor, and that all went well under the Anakinra treatment. One interesting fact is he had an FMF attack a few days after his transplantation. The transplantation went so well that his renal function improved very quickly, and we think it's because he was still on the once every 2 days dose of Anakinra. So we increased the dose of Anakinra, and he went well after that. And he's now doing fine. He's married, and he's hoping to become a father soon. So that illustrates some of the problems with follow-up of a patient, the things to be aware of, and the goals in management. These may be a bit open doors. That may be a Dutch expression, maybe not be an English expression. At least these may be obvious things for a chronic disease, but it's good to be aware of it. So apart from that, we try to get the inflammation down and the number and severity of inflammatory episodes down. Also keep an eye on the quality of life of the patient, other things that may be going on, and also try and prevent long-term complications and the damage that is caused. And this was a group effort of a lot of experts, clinical experts. We tried to put together some general recommendations for these 4 prototypes of diseases of what to look out for. So I recommend you take a look there. And this is just for me to remind me what I could be talking about. Yes, so one important thing is that follow-up for the amyloidosis risk. I check my patient's urinary sample once a year, as long as everything's going fine. As soon as you see some protein or you suspect some protein, then you need to take further action. So a 24-hour sample, seeing your patient more regularly, making sure there is there inflammation going on or not. I would also suggest a low threshold for consulting an expert. None of us can know everything about all diseases, so if you're struggling with a patient and you don't know what to do, there's always other doctors in the same country or the same town that know about these disorders. In many patients, a multidisciplinary involvement is recommended. Neurologist involved, or for the hearing loss, the ear, nose, throat specialist, etc. An important point, I think, is patient education. In my view, for these chronic diseases and lifelong diseases, it's good to empower the patient about their disease, to give them, well, maybe not part of the responsibility. The responsibility for good treatment is still with the doctor, but you can ask something of the patient as well, and that will also improve compliance. If the patient knows why we're so insistent on drug taking, even if the patient feels fine, that usually helps. And in some cases, don't forget psychological support. It's not nothing to get a disease like this, and it has effect on all kinds of things in life. Just some tools that I use in clinical practice. This is a kind of, is a disease activity index, AIDAI. This was validated for the 4 prototype inflammatory diseases. It's been validated for use mostly in trials, so in research, to get the groups or to get comparable results. But I do use it in clinical practice as well. It's just an Excel sheet or a printed out version. I use it at times when patients are new to their disease and are not really sure what is all part of it and what the pattern is. And I use it when there's some issues with treatment. So if you want to increase treatment or use a new drug, I usually get patients to fill this in for about 2 or 3 weeks before changing the drug and then afterwards, and you get a better impression of what's going on and what the effect really is. Another index that's still being validated for these 4 diseases is a damage index. Again, that's mostly being developed for research purposes. These are damaged items that are not related to disease activity. So there's not fever or arthritis is not in it. It's just damage that has been there and is there for more than 6 months. There are several items, amyloidosis, of course, some developmental defects, hearing loss or ocular damage, all kinds of bone deformities, and also infertility issues. And again, that's mostly for research purposes, but it might trigger you to think of damage that you might want to keep an eye on in your patient. And lastly, just a few comments about pregnancy and drugs. In these disorders, when the women get pregnant, often it's the clinical impression and the patient's impression that they get less severe disease during their pregnancy. Of course, pregnancy has a huge effect on your immunological system, but I have patients who say to me, "Oh, I've never felt so good as when I was pregnant because I didn't have any attacks at all." On the reverse side, as soon as the delivery of the baby is there, they tend to get a very severe attack. So I usually warn patients and their midwives for that, that they still check for infectious causes, of course, but they have to be aware that it might just be an attack of the disease. Now, to go on to drugs that patients may be taking. Oh, by the way, uncontrolled disease. So it's not an option just to stop the drugs and get the disease, very active inflammatory disease, and then have a pregnancy, because that has also bad effects on pregnancy and the birth. So it's a tight, sometimes difficult. For colchicine, it's clear. It has been studied a lot in bigger studies. Colchicine use has no significant effect on fertility, pregnancy, or breastfeeding. So I really urge all my patients and the gynecologists they're usually seeing that they should continue that. And it's good to be aware that most gynecologists advise patients to stop it. So I usually get involved and I'm insisted that they do continue it. For Anakinra, less is known, of course. In the literature, I think there's about 36 pregnancies now with varying amount of Anakinra exposure during the pregnancy. A lot of healthy, uneventful pregnancies, but there were 2 babies of the 36 that were born that had renal tract abnormalities, which normally occurs in about 1 in 1,000. So that's something to keep an eye on, whether that might be related to IL-1 or whether it's just a coincidence, we don't know. But in case, and breastfeeding seems to be okay in the 10 cases where it's been done. The advice is, I discuss the risks and the benefits. I try to stop or consider stopping, and if not, I do continue it in some cases. And then lastly, Canakinumab, even less is known. It is an there have been 7 pregnancies that seem to have gone okay, but it is a monoclonal antibody, so I would be a little less certain about continuing it, especially because it has a long half-life, so you can't really stop it at some point where you're not happy anymore. So yeah, if really necessary, I would sooner switch them to Anakinra. So in conclusion, IL-1 inhibitors have transformed the outcome of these autoinflammatory syndromes. There are some alternatives if they don't work that I didn't discuss very much today, the TNF or IL-6 inhibitors. Don't forget the colchicine and FMF. And watch out for compliance, complications, and quality of life during the follow-up. So that was my presentation.
Fantastic. Thanks very much, Anna, for such a comprehensive overview. We're really running out of time, and I'm conscious of the fact that, I know, it's just very bad sharing. I'm very conscious of the fact that we have a patient and family session coming up, and Anna's going to be on the panel, so unless you have a burning question, maybe you should save it for the next session, because
for the drinks as well, so you can ask.
So we might just move straight on to that if everyone's fighting fit to continue.
Okay. Thanks, Tree. So that actually brings us to the end of the scientific session today. I think it's been fantastic. We've really covered a huge amount in a relatively short time, and it's really given us all a lot of things to think about.